so honored to be here with you all today at Diversity and Diabetes' fourth People of Color Living with Diabetes Summit. My name is Jordan Major, and today we will explore navigating type 1 diabetes in pregnancy, realities, risks, and resilience. So a little about myself. I have been living with type 1 diabetes for 32 years. I am a mom of two rambunctious boys. Both one is 2 years old and the other is 4 years old. I am an occupational therapist, and I am also a PhD candidate studying type 1 diabetes in pregnancy at the University of Florida. This topic that we're discussing today, type 1 diabetes and pregnancy, is deeply personal to me. When I was pregnant, I experienced firsthand how complex, isolating, and frankly, sometimes frightening it can be to navigate a healthcare system that often isn't designed for people of color or marginalized people. So, despite being a healthcare professional myself, I still encountered bias, judgment, and moments where I felt unseen and unheard. Those experiences changed how I view care, not just as a patient, but also as a clinician and a researcher. Professionally, I've spent more than a decade as an occupational therapy practitioner, working with people, managing chronic conditions, helping them build routines and environments that support their health and participation in daily life. And now I work with pregnant people with type 1 diabetes, assisting them with their daily management and essentially how to handle the unpredictability that can arise during pregnancy with type 1 diabetes. Through my research, I focus on diabetes distress and pregnancy and how stress, bias, and systemic inequities affect people of color living with type 1. What drives my work and this conversation is the belief that pregnancy with type 1 can be safe, joyful, and empowering when we're supported and respected. But to get there, we have to confront the barriers as well as the emotional labor and the lack of representation that so many of us experience. So today, I am here not just as a researcher or as a healthcare practitioner, but as someone who's lived this story. Um, so I'm here to share what we know in terms of, the research that's out there, what we still need to change, and how we can create systems of care that allow all of us to thrive. So I know I'm preaching to the choir here for the most part, but I do want to make sure I give an overview of type 1 diabetes for those who may not be familiar. So, type 1 diabetes, or T1D, is an autoimmune condition where the body's immune system attacks the insulin producing beta cells in the pancreas. And without insulin, glucose can't enter cells for energy. So what ends up happening is that glucose stays in the bloodstream, leading to high blood glucose levels. It's important to also note that type 1 diabetes is not preventable, and its cause has nothing to do with diet or lifestyle. It is a lifelong condition that requires careful daily management that involves insulin, glucose monitoring, nutrition, and physical activity. So for most people living with type 1, that means using multiple tools like insulin pumps, injections, continuous glucose monitors, and making dozens of decisions each day to stay safe and healthy. Okay, so now that that's out of the way, let's take a moment to review how far we've come in terms of what we know about type 1 diabetes and how it's managed now versus a long time ago. I'm also going to highlight why this topic is so important. So as you can see here on the screen, before the discovery of insulin in 1921, um, pregnancy for people with type 1 diabetes was almost always fatal. So most birthing people or women with type 1 didn't survive childbirth. And if they did, their babies often didn't. Doctors frequently advised against conception altogether because they just didn't have the technology or the knowledge to understand how to ensure that a type 1 pregnancy was safe. Even after insulin became available throughout the 1930s to the 1950s, maternal and infant mortality rates remained extremely high, largely because blood sugar monitoring was limited and insulin regimens were inconsistent. They didn't, now that they had insulin, they weren't totally sure how it impacted each person living with type 1. So in the 1960s and 70s, advances like self-administered insulin and the introduction of home glucose monitoring began to change those outcomes, but pregnancies were still labeled high risk. So many people with type 1 were told that they shouldn't have children, which was a message that especially impacted women of color who already faced systemic barriers to care. By the 1980s to 1990s, with the development of continuous glucose monitoring, insulin pumps, and better obstetric coordination, outcomes improved dramatically, with many people with type 1 now having healthy pregnancies and healthy babies. However, even with these advances, disparities still remain. So people of color, particularly Black birthing people, as well as other marginalized birthing individuals, continue to experience worse outcomes, not because of differences in disease management, but because of inequities in access, quality of care, and the cumulative effects of bias and stress in healthcare settings. So when we talk about risk today, it's not just about a lack of effort or knowledge. Um, it's about systems that still fail to meet us where we are. The goal isn't to scare anyone, but to remind us that context definitely matters. And every blood sugar check, every appointment, every ounce of advocacy is shaped by that history. So when we talk about pregnancy and type 1 diabetes, I want to start by saying this very, very clearly. Having a healthy pregnancy with type 1 diabetes is absolutely possible. It takes work and significant support, but it is definitely attainable. The image that you're seeing here on the screen helps show just how much a pregnant person's body changes during pregnancy as it relates to their insulin needs. So you don't need to memorize the curve or the numbers that are on the chart here that I've displayed, but I just want you to know that it simply shows that your insulin needs go up and down throughout pregnancy, especially as hormones increase later on. And those shifts are very normal. But what that means is it makes pregnancy with type 1 require a lot of attention and adjustment. So with that said, blood sugar checks often happen more frequently. Insulin doses are changed sometimes every few days to every few weeks. It just depends on where the person is in their pregnancy, as well as how their body handles insulin. So for pregnant people living with type 1, they spend a lot of time communicating with care teams. So usually the care team will include an endocrinologist, an OBGYN, a diabetes educator or nurse, sometimes a perinatologist, which is a high-risk doctor, or a high-risk pregnancy doctor. And that teamwork and communication really matters. So managing type 1 during pregnancy can feel like a full-time job, but it's one that you don't have to do alone. But again, that team and that comfort and that communication is very, very important. It's also extremely important to note that the goal is not perfection. It's partnership between you, your care team, and your support system. One of the most important things I want to highlight is preconception care. So essentially what that is planning ahead before actually becoming pregnant. And I know that's not the easiest thing to do. And a lot of people don't necessarily plan ahead to get pregnant. But working with your providers early can make a huge difference later for your pregnancy and even beyond. So that preconception care can give you time to actually bring your A1C closer to the target range, learn how your body is responding to insulin, and talk through safe medication and lifestyle changes that may improve your outcomes before pregnancy, during pregnancy, as well as after pregnancy. Going into pregnancy with good preparation can significantly lower the risk of complications for both you and your baby. Um, Even with all that effort involved, pregnancy with type 1 can be incredibly rewarding while also incredibly difficult. It teaches you how resilient your body is and how capable you are. The ups and downs you see in this chart, again, aren't failures. They're just part of the process. So again, as pregnancy progresses, insulin needs also increase. And that's why it's extremely important to make sure that you have a team that you feel comfortable with and that you can communicate with. Okay, so when you're pregnant and living with type 1, there's this constant emotional pressure that I feel like not a lot of people talk about. Um, and essentially, it's like you're managing two lives at once, and every number suddenly feels like they're higher stakes. So I want to point out the concept of diabetes distress. So diabetes distress is what we call that feeling of frustration, worry, guilt, and just kind of burnout that comes with trying to manage diabetes all day, every day. It's not the same as depression or anxiety, but it can absolutely wear you down. And during pregnancy, that stress often grows because you're not only managing your own health, but also protecting your baby. The American Diabetes Association and the American College of Obstetricians and Gynecologists recommend keeping your hemoglobin A1C below 6.5% and ideally closer to 6%. And while that's a good goal to aim for, it's definitely not easy. Reaching those numbers can mean more frequent blood sugar checks, waking up in the night to correct highs or prevent lows, and adjusting insulin doses every few days. It's truly a full-time job layered on top of pregnancy itself. So again, I think there's more and more discussion about this, but not not that much at current. But what's important to remember is that these targets aren't about being perfect. Again, it's not about perfection. It's about finding a healthy balance and doing what works best for you and your family. So even small improvements in blood sugar management can make a meaningful difference for both you and baby. So if you're ever feeling overwhelmed, that's totally valid. It's okay to say that it's hard because it is. And what matters most is staying connected with your care team, your community, yourself, your support systems. So you're doing something incredibly difficult when you are deciding to have a baby and living with type 1. And it's incredibly powerful, and you deserve support every step of the way. All right, so statistics tell us that pregnancies complicated by type 1 diabetes make up about 0.2 to 0.5% of all pregnancies in the United States. This means that out of every 1,000 pregnancies in the US, between 2 and 5 of them involve a person who has type 1 diabetes. Now, when we talk about it like that, doesn't really seem like a lot. Seems like a pretty small percentage, but it represents a significant population due to the higher risks associated with managing diabetes during pregnancy. So these pregnancies are 2 to 5 times more likely to result in morbidity, or uh, which morbidity are those are complications or mortality than those in the general population. So this highlights the fact that individuals with type 1 have a much higher risk of experiencing severe complications or even death during pregnancy compared to people without diabetes. Specifically, they are 2 to 5 times more likely to face these adverse outcomes, like those mentioned, uh, like I mentioned previously. So again, this underscores the need for special attention for people that are pregnant living with type 1. Another little tidbit that you might find surprising, for all the research that exists on type 1 diabetes and pregnancy, very little of it actually represents marginalized populations. So Black, Brown, Indigenous populations are not accurately represented in those numbers. Most studies have been done on small groups of white women with access to specialized care. So this means when doctors quote statistics or set treatment goals, they're often basing them on data that doesn't include Black and Brown birthing people or people with different income levels, family supports, or healthcare access. And so we know that when you don't see yourself in the data, your real life experiences, like your stress, your cultural context, your barriers to care, all of those things can actually get overlooked, or they can actually be misunderstood or misrepresented within the data. So it's one reason why so many of us feel unheard, even when we're doing everything that we should do to manage our diabetes. Research also tends to focus mostly on numbers. So blood sugars, A1Cs, complication rates, but not enough on the human side of living with diabetes during pregnancy. So again, as I mentioned previously, the emotional side, the burnout, the fear, and the strength that it takes to keep showing up every day as a person living with type 1, and particularly as a person living with type 1 and also carrying a baby. So that's why more inclusive research is so important. We need studies that reflect our stories, our challenges, and our successes, because when our experiences are represented, the recommendations get better and the care becomes more equitable, which improves the outcomes for everyone. So as we move forward, again, we need to remember that it's not just about collecting data, it's about actually collecting our stories and sharing our voices with everybody so that they see that our stories are also data as well. So the most powerful strategy, as I mentioned before, is preparation and partnership. These are things that are going to help, and they're evidence-based and live strategies that will support a person or you during your pregnancy with type 1. So if you're thinking about pregnancy, meet with a team early, but make sure it's your team. So people who will see you as a collaborator and not a problem. I want to really, really, really emphasize here that you are the expert in your body. You are the expert of your care. You are the only one that truly understands what you go through on a day-to-day basis. So it is really important that you feel heard and supported when talking to a team. And again, that team feels like a collaborative experience. Um, so that can also include, in addition to the folks that I mentioned earlier in terms of a healthcare team, that can also include doulas, it can include peer mentors, or just other people living with type 1 that just get it. So remember, perfection is not the goal, it's consistency, support, and self-compassion. Okay, so in terms of centering equity and respect, even with all the technology and medical advances we've talked about, not everyone experiences care the same way. So equal access doesn't always mean equitable care. For many Black, Brown, and Indigenous birthing people, bias in healthcare is a reality. So being questioned, not believed, feeling judged instead of supported, unfortunately, can happen and does happen. So when you add the complexity of type 1 diabetes, those interactions can become even more stressful. So centering equity means more than just treating everyone the same. It means making sure people are heard, respected, and given care that fits their lives. That might look like a provider slowing down to explain options, respecting your choices, or helping you find resources that truly work for you. Representation matters. So when care teams and researchers include people who look like us and understand our communities, trust grows and outcomes improve. So as we move forward, let's remember the best care doesn't just focus on blood sugars or A1Cs. It's about listening, respect, and partnership. And that's what makes care equitable, and that's what makes it healing. So a huge piece of managing and navigating type 1 during pregnancy is also building community and advocacy. We heal and grow in community. So sharing our stories creates collective power. We influence how care is delivered, how studies are designed, and how stigma is dismantled. So community spaces like diversity and diabetes can truly be really great spaces for us to feel safe and seen. One of the most powerful parts and important parts of living with type 1 is the community that comes with it. So when we connect with others who truly understand what this journey feels like, we realize we're not alone. Advocacy doesn't always have to be big or public. Sometimes it looks like sharing your story online, mentoring someone newly diagnosed, or just asking for what you need in a clinical visit. Every time we speak up, we make it a little easier for the next person to be seen and supported. So together, our voices help shape research, policy, and the culture around diabetes care. Community is how we return to, or how we, I'm sorry, community is how we turn lived experience into change. And again, diversity in diabetes creates that space for us to breathe and feel seen. So if there's one thing I hope you take away from today, it's that pregnancy with type 1 diabetes is absolutely possible. And it's okay if it takes planning, support, and grace to get there. In fact, it should. Managing type 1 isn't about being perfect. It's about being consistent, asking for help, and knowing you deserve respectful, equitable care. Remember that your health and your story matter. You're the expert on your body, and your lived experience has power. So it's not just for you, but for the whole community. And sometimes sharing those experiences and uplifting your voice as well as other voices help others feel less alone. So as you reflect, I want you to ask yourself, what kind of support will help you feel safe and confident managing your diabetes through big life changes like pregnancy? That's where your next step begins. And it should also be supported by community, and encourage you to trust in yourself and know that you belong. Thank you all so much for your time. Please feel free to reach out to me via email or Instagram with any questions, comments, or feedback. Again, I am in this with you, and I'm more than happy to help however I can. I look forward to the next time I can be in community with you all.